So I wasn't going to say that I was nervous, but it's, always, well, everybody's out there. So hi, everyone. I just wanted to get a sense, how many of you guys are in the BSN program? Are into BSNs? Master students? So we have more masters and some faculty. So we're going to go through what was my dissertation presentation. I've condensed it, and it's very hard to do, but I hope you guys are going to get kind of an overview. My study was on occupational health, and I made these objectives not because I'm going to teach a class. This was to kind of try to keep me in line so that we can get through some of this information. I hope that some of you will find this interesting. So we're going to talk about operational definitions first. We're going to introduce kind of what my purpose and goals were with the study. And then I'm going to try to follow like a traditional journal style to kind of get through the information. And then maybe we can have some discussion because we have the future of nursing here in this room. We have future leaders. Any nurse managers here now? Current nurse managers, administrators? So I think that it's very important that we talk about the vocabulary and the words that we use when we discuss, because when I remember trying to do my proposal and talking about occupational health and different perceptions people have of just those terms. So we're going to start with the definition of occupational health. And this diagram here is the World Health Organization diagram of occupational health. But it's basically a field that's not just concerned about how we communicate with each other, but also kind of the whole work environment. Is this a healthy place for people to work long hours every day? We know nurses work really, really hard. Stress, what does that mean to you? I'm a little stressed right now here talking in front of the group, but occupational stress for this study is defined as sources of stress or daily pressure experienced by qualified nurses with some manager experience. So Harris and Cooper used this instrument, and I found it throughout the literature over about a 10 or 15-year period. It's not used a lot, but it was designed specifically for nursing, and I wrote a paper on the instrument, and it had really good Cronbach's alpha. So I chose this instrument to measure stress. Then workability, what's that? Anybody, what comes to your mind when I say workability? Does it just mean being able to get to the job and do it and survive your shift? Does it mean after 20 years, almost 2 years of nursing, that I can walk and still function doing other things? The Finnish Institute of Occupational Health started doing work in the 1980s on this because they knew the workforce was aging and they wanted to start looking at the workplace and making it healthy. And so this came from a kind of me synthesizing the Finnish Institute of Occupational Health and then these other authors into the definition that I used. I wanted these to be close to the instruments I was using. So occupational competence, how good are you at your job? And individual health, I have to be able to move patients in my job. I'm a circulating nurse. I need to be able to do that. Do I have the mental resources, the emotional intelligence, those things I need? And then what are my values and motivation? Occupational virtue is kind of a nebulous term, but values and motivation is what that's going back to. Why am I doing my job? Because we all know as nurses that some days you have to dig deep for that. You have to kind of get inside and go, okay, why am I really still doing this some days? And then what about our nurse managers? How are we going to define them? So if any of you don't know, nurse managers are usually always responsible for the units 24 hours a day, 7 days a week, and that's a lot of responsibility. There's also a scope of service document. Has anybody heard that word before? Scope of service? So we have Joint Commission here, and they could ask for the scope of service for any unit that they go to. So if you guys are getting a job, interviewing for a job, you're in a unit, it might be interesting to look at that and take a look. It'll define for you what kind of patients we treat, what kind of staff we have, things like that. So background, how did I end up on this road? Does anybody have any questions about the definitions so far? Okay. I was, in a roundabout way, I ended up at a critical access hospital called Seton Eggerby Davis. Have any of y'all ever worked at little hospitals? It was part of a larger network, though. It's an Ascension Health hospital, so we had a lot of systems in place. So I started off working in their ER and med-surg, and then I got to be an infection control nurse, and I was on their leadership team, and what else? We had Joint Commission readiness, and we had process improvement projects. So I felt like I really got to see like a little hospital, but all these parts that were very well organized. So it was a blessing to me to be there and work with those folks. And so I worked for this nurse manager as a supervisor, and I just started looking at everything this person was doing. You know, everyone's back in school. Staffing. I mean, is that it? Staffing? If nurse managers could get rid of staffing problems, everybody could go home. It would be just great. We have metrics. We've got financial metrics. We've got patient safety metrics. What about covering shifts? I had a vice president say to me one day, well, the nurse managers aren't covering shifts. I said, yes, they are. And so I put that in my questions when I did my survey. What about committee meetings? Human resource issues. I talked to one nurse manager at Adult Children. She's like, well, where I had worked before, I never had to do HR issues. But here, I'm dealing with FMLA. I'm dealing with all these things. So there's a lot of variables and a lot of variability. And then compliance. You know, we know Joint Commission is here right now at Covenant. So, and then going back to the literature now. Institute of Medicine report. Everybody know about this report? Very important report, Future of Nursing Leading Change. We want healthcare that's high quality, right? We want it to be efficient, we want it to be safe. Nurse managers impact all of this. It really matters. It really, really matters. I can't stress that enough. The leadership you have. You go to drive a project for change, and if you don't have that executive owner that's on board and helping you drive, you're really not gonna, you might get somewhere for a few days, but it's not gonna go as well. We need new workplace cultures. 4 or 5 generations of workers in the workplace. I'm married to a baby boomer. I'm a Gen Xer, okay? I'm not a baby boomer. I want my vacation. I use all my PTO. You know, we just have different things. But we need we want to work at Google, right? Where they've got a salad bar and all that. And then what about nurse managers in the United States? What is our current workforce like? And are we going to be able to find the evidence we need to support nurse managers, okay? And call it evidence-based practice. Well, we feel this way. You know, well, we think this. You know, we have all this anecdotal stuff, which is nothing wrong with that. But I learned something in TCAB, which is Transforming Care at the Bedside. It was an IHI project. If you don't start looking at data, even if it's just your little tick marks on your thing, you really don't know what's happening, and it'll surprise you. Because you'll think, well, gee, I'm expecting this, and then you're going to get something different. So, evidence-based practice. So now going to the nurse manager role. It's evolved. It's changed. Everybody knows that. Do we really think about it? So the nurse manager used to be a head nurse, and they were very task-oriented. It was the best nurse on your unit. It was the nurse that could start every IV. They were the best clinician, you know. Now we're expanding that role, and it's evolved. And it can't just be about being the best clinician anymore. So what we see anecdotally, right? Well, I think it's in the literature a little bit. The nurses with best clinical skills often get promoted into these roles, or it's the person that will do it, you know, or whatever. But it's really complex. There's like so much there. And one of my committee members, he was the CNO at Dell when it opened, and someone asked him, you know, well, do you think what happens when a nurse manager gets a master's degree? And he said it broadens their view. It doesn't necessarily make you a better clinician, but it's going to open up your view to the world. Competency sets. Have you guys heard of the American Organization of Nurse Executives, American Association? Very important. So for those of you in the room that are younger nurses, join your professional association. I'm an AORN. They are very important. And these two fabulous groups developed these 3 learning domains with 15 competencies. That's a lot. The IOM report says, yeah, we need leadership skills depending on context, time, and place. So the literature is telling us that we need these things. So going back a little then, again, to our occupational health science, are we providing workplaces that are safe and optimal from a physical and a psychological standpoint? And in the context of these progressive evolution of these roles, are we keeping pace in our workplaces? I would say I don't think so. I don't think our workplaces are healthy enough. I hate to say that, but when I go to the cafeteria, I'm just discouraged. You know, I mean, no, I'm not perfect. Everyone's going to eat burgers. But I mean, I loved the kale with the raisins, and they took it away. And I was like, really? And some of it's culture. It's what we're used to. But how are we designing these jobs to support the nurse? You know, and I had, in that little hospital, we hired a project manager who had a master's degree in healthcare, great first job out of a master's program. He crunched all our numbers, and he could show us that stuff every month. Not all managers had that. You know, I was talking about the variability in what these folks are out there doing, because the roles bloom and evolve, and then we try to catch up. All right. So go, and then back to our Finnish friends, the 3 trends behind the research on workability and occupational health go to aging of baby boomers, structural changes in work technology, and this is getting to be one that I'm thinking about, rethinking of traditional retirement age. Really, I got to work to 67 to get my full Social Security after I've been slaving for, and we pay for that money. So you start thinking, can I be a circulating nurse when I'm 67? So probably not, but I don't know. But these are worldwide trends. This is not just in Finland. This is here in the United States as well. So the nursing workforce that we have, I went to several studies. We have an average, many are baby boomers over the 50, median age of 52. That's a lot of nurses, 34,000 nurses they were. And the IOM also reported, I think the average age of OR nurses is like 54. That's a few years older than me, but not much. And we love our younger nurses too. We want them to be happy. We want, this is why I moved to Lubbock right here. But, so we want to take care of all the generations in our workplace. So that kind of, I hope, gives you some background as to why I did what I did, okay? We have to have theories in nursing. I love theories. PhDs love theories, it's just great. So I had to look at a lot of different theories when I did this study. I looked at the stress literature. Zellier is the founder of modern stress theory, and you can go, we even had a psychoneuroimmunology book in nursing, my nursing PhD program. So we know that these things are linked. The Workability House is a model that came from the Finnish Institute of Health. I used their instrument, the Workability Index, and so this was their model, and I wanted to stick really close to the folks that have been doing all this good work in Europe. And it shows the house here, work community, leadership, values, attitudes, competence, health, and functional abilities. Because I do think our cultures really do support what we do every day. And then, does anybody know Betty Newman? I actually got to hear her speak. Went to the Newman Systems Conference, and I guess she's still around. But if you look at the early nurse theorists, I can't see my notes, but Callista Roy, Betty Newman, a lot of them had psychology degrees, and they worked a lot around stress theory and adaptation. And so I just felt like this really fit. We won't go into all the little details there, but. So the purpose of my study was to get more quantitative data. It was an exploratory inquiry on job stress and workability nurse managers working in acute care hospitals in the United States. So you always have to limit. So I limit it to just acute care. And then I want to support the business case for well-designed evidence-based nursing management. So anything we're doing at work, you can say, well, this is nice or that is nice, or gee, the role is, but if we don't support that, with what is it, initiative, what do they call it, return on investment, why are we losing OR minutes, or, why do we have to support these nurse managers? Is it for retention? If we can't learn as nurses to do business case, we're not going to get anywhere. So, and then my hypothesis that work stress experienced by nurse managers in the U.S. may be impacting their workability. Maybe it's going to impact our ability to stay in the workforce and enjoy our work. I really cut out a lot of the literature review, but I was telling one of the faculty here, if anybody has any questions, please email me. I have lots of literature. In fact, I sent a picture to my chair of all the literature out on the dining room table. She said, you could write 3 dissertations with that. So anyway, I used traditional search methods, CINAHL. More interestingly is I did get some seminal works, like books, and then linked articles. Pop-up suggestions work. You just have to make sure that you cite them and that they're good sources. And then the FIOH, the Finnish people, did send me some things electronically that I couldn't find. This is the literature review, right? You never get out of it. So, but these are the themes that emerged: stress in the workplace, nurses' work and health, nurse managers and stress, and nurses and workability. So I did keep a few of these slides. The nursing, work, and health. What I wanted to focus on, I want you guys to take away from this, is that when we're talking about healthy workplaces in the U.S., and we've been doing it for a while now, we're talking about care environment, outcomes, and staff satisfaction and retention. And key influencers are communication, collaboration, leadership. Aiken is there. They're also associated with professional practice environments. We talk about nursing excellence. We talk about magnet. And if you go to those, standards, you'll see a lot of it is around communication. This is probably too small, but skilled communication, collaboration, decision-making, appropriate staffing, meaningful recognition, and authentic leadership. So these are the 6 essential standards from, they did wonderful work, American Association of Critical Care Nurses. And I love the IOM, the Institute of Medicine, and also American Association of Colleges of Nursing. So these all kind of align. But that's real, focused on, the nurse and that smaller picture, not necessarily the workability house or the WHO model, which is physical work environment, personal health resources, community, psychosocial work environment. So I think we've done a lot of work here to get rid of bullying, to open lines of communication with physicians and things like that. I think we could do a lot more here. Like in Australia, they've done a lot more with lift equipment and things than we have here in the United States. What about that cafeteria? I shouldn't go down there and go, oh my gosh, is this supporting a healthy lifestyle? Are we building a culture like that? Burton, this is from the World Health Organization definition, and Burton wrote this paper, and that's their definition. Does everybody like that? They like the idea of we should work someplace that we can be healthy? Yeah? No? Anybody who's worked in other fields and then come to nursing? That's always kind of interesting too, because you get to see that the world's different in other places. So basically, the research does show that the work of nurses and nurse managers is stressful. It's focused on coping, stressors related to relationships, resources, roles, span of control, and health and economic impact of nurse managers. Are we having retention issues? And many of these studies have been done, they're either qualitative or they were done outside the United States. And I think Shirey is the one that I think of all the time. But and I actually got her dissertation, and a lot of her stuff was Midwest. And so there really was a gap in quantitative stuff out there. The IOM says we need more data. We need an effective healthcare workforce. But there was no specific mention of nurses' workability or workplace design, healthy workplaces. I think we need to be more innovative here, and we need to think way outside the box of what we're doing for our staff and ourselves at work. Retention of both new generations of millennials. Millennials just, what do they say right now? They're just leaving if they're not happy, and they want more vacation. I'm probably not as extreme as the millennials, but I'm still taking all my vacation. And then what about our nurses over 50 that I get to be in that group now? Are we going to employ these folks, or are we going to put them on disability or send them to work at Walmart? I'd like to work with experienced folks too. And I've talked about the European focus. But going to that, over there was so much in the next study. Have y'all heard of the next study? And that did have all the literature about early exit from nursing, early disability and retirement, and then the quality of your retirement were all linked to workability. So if you have high workability, you're not gonna leave, you're gonna have a better retirement with less disability, and you're gonna have a higher quality retirement. Any questions? Are y'all understanding my instruments? So I have 2 instruments that I'm gonna use. Workability Index, which has never been used in the United States, and then I have the Nurse Stress Index. Okay, let's see. I don't think there's anything else here I haven't said, except I just mentioned that this was my big gap. When you do a PhD, you have to have originality. You have to have something original. You can't repackage other stuff. So my primary purpose was to address these gaps and look at the current state of workability in nurse managers, get more quantitative data on job stress levels in nurse managers. I looked at some relationships. I'm only going to talk about my first research aim today. I'm not going to go into logistic regression because my head would explode and we don't have enough time. But I wanted to contribute evidence-based knowledge to this because I'm so passionate about the importance of our leaders. And then also, I think even more, taking care of nurses. We spend our lives taking care of other people, and I think we need to take better care of ourselves. So, all right. This is always fun. My chair was a statistician. How lucky is that? She was a biobehavioral statistician, so I was really lucky to have a good chair. So it was quantitative, non-experimental, and exploratory. I used the 2 instruments, the Nurse Stress Index, which is a very simple instrument. This was a little more complex instrument here. And then I asked my question, do you pull shifts? I wanted to know. I wanted to prove that vice president wrong. Yes, nurse managers are working shifts. And I now have data to prove it. So that's the workload variables. And then I use like standard demographic questions. I use SurveyMonkey. Anybody what do y'all use here if you're doing any questions? Anybody doing a study? No? Okay. I went through the IRB, And my basic inclusion and exclusion, I wanted English-speaking, reading, writing nurses working in acute care. I didn't include critical access hospitals because I wanted to make sure I wasn't getting skewed, because I know how different rural healthcare can be. And they had to be supervising people that were giving direct care. It couldn't be somebody that just is like a manager, but they don't really have someone that's giving care to patients. Because one of the reasons I think this is so important is because if you don't have a talented nurse manager with both leadership and managerial skills, you're not going to translate that stuff to the bedside. You know, you're not going to get those nurses turning the patients every 2 hours or get them to give you the ideas to make their workplace better if you don't have that. So, all right. So it was online, multimodal. I used nursing professional websites, my personal social networking sites. I had actually gotten off Facebook, but I had to get back on. And then I made one purchase announcement with AONE, and I did 2 waves of postal mailing. That was fun. And I used the U.S. geographic map for the census to make sure I hit all 50 states twice. 163 people opened the link. 63 didn't meet criteria, didn't finish. And then I had a final N of 92, which is very disappointing. Any people who love statistics in here? Anybody? I wish I was better at it. But you have to have 100 to do factor analysis. So I was not going to be able to factor analysis my scale because I didn't have enough people. But eventually you go on, and we did have 100% completion of the 2 instruments. So the Nurse Stress Index had 6 subscales that all had to do with nursing. So it really wasn't, that's one of the reasons I chose this instrument, because it was nursing oriented. It wasn't really about, it does have one homework conflict, but dealing with patients and relatives, confidence and competence and role. These are things that we think about with nurses. And then the scoring, the subscales. Everybody understand what a subscale is? So you get a total score for your instrument, but then it's broken down into those 6 subscales. And so you're going to run Cronbach's analysis on all of those subscales, but your head's going to explode now. Okay. The workability index had 7 dimensions. So their current workability compared with their lifetime best, workability in relation to the jobs, how many diagnosed illnesses do you have or limiting conditions? So I did have to be real careful with this because it was asking for health information, but there was no way to connect, the respondents to the information. How much sick leave has the person taken in the last year? What is their prognosis of workability in 2 years? And what is their estimate of their mental resources? So you end up with workability with like 4 groups. 7 to 27 points is poor, and they need to restore their workability. 28 to 36 is average, and then we want to improve their workability, give them a little more resilience. We need to build them up a little bit. These folks in the good to excellent need support, but they're doing fine. Then it gets to the point where for statistical analysis, we had to make 2 groups. So don't worry too much about that, but we made 2 groups. So the first aim, I actually had 2 aims and 5 research questions, and we're just going to look at the aim 1 stuff here. So I measured the baseline job stress and the workability scores. And let's see, what did I get? Surprising results, of course. So here's my Cronbach's ALEC. So everybody know, when I say psychometric analysis, does anybody know what that means? It means you need to hire a statistician or have one on your committee or have a friend who's one, because honestly, I think as a PhD it was very important that we learn to evaluate research articles, but if you're really doing something like this, there's no way that I know enough statistics. Even with a really good book, you still need someone who's really expert. But all of our Cronbachs were good, basically, except DPR was a little low, but it was still good. And then only 2 sections of my workability index met criteria to run that statistical test. Any of the younger students, why do we run statistical tests on our data? Does anybody know? It's okay if you don't. Someone guess. Where's Stacy? Did Stacy leave? Sheila. Yeah. Oh, no. Well, we have to run the statistical test to look at the validity and integrity of what we've got, the results. So this is telling us, is this subscale really measuring these elements of the index, okay? All right, and this is I like to spend all my time talking about the sample and not go any further, but what do we expect in a sample of nurse managers? They're mostly women. They're mostly white backgrounds. And if you'll see, this is kind of cool. Most of them have a bachelor's or a graduate degree. I don't know. And then how many years of experience? A lot of folks in the 1 to 8 years experience. Remember, this is 92 people. Some in the 9 to 16, then you get down here to people that have been there forever. How do you be a nurse manager for 33 years? That's a long time. I don't know. I was very proud of this because some of the other literature I read was, like I said, it was regional. I had representation from all the regions of the United States. You would expect this to be more in the South because I'm from here. And so at the end of your study, you're like calling your friends and you're saying, can you please get me just a few more people? A lot of people here took it because I was working at Covenant, and so the managers there helped me. What about nursing excellence designation? I really, really believe in this, by the way, because it brings resources to nursing. It's really so much more about the it's not about the finger paint. It's not about it really brings resources to nursing. But pathway to excellence, 27%, magnet 21%, but the majority of my sample had no designation. This is our hospital size. Most of the folks were in larger hospitals of over 300 beds. And then acute care, critical care, procedural areas like OR, and then other. And so you have to, I just start thinking about, well, how is it, first of all, who's answering this survey? I mean, I was a graduate student. I usually answer the survey. So you also kind of have to have that in the back of your mind. Let's see. Management arrangement. Here's my favorite question that I asked. Direct care, including whole shifts. Most of my sample is taking care of patients, and they're pulling shift. I was a nursing supervisor, and you get that phone call in the morning that, Susie or John hasn't come. Well, you're not going to do your work today. You're going to go do the patient care because that's what's most important. But it can be hard on you because then all your work is still there. And if your administrators don't understand that, then it can build up to be a bigger problem. So direct care but not whole shifts, and then only I think that's 20 people were doing absolutely no direct care. Work alone or assistant, these people are working by themselves, 38. 5 people had co-managers, and the reason I asked that question was because Shirey found in some of her qualitative research that co-managers reported less stress. So I only got 5, but we do see some hospitals at UMC. Do you have any co-managers? I don't know that we have any at Covenant. I think I heard some, at Seton we had some. I remember there were some floors where there were 2 managers for a unit. I don't think I put the direct report slide up here, but you'll see some managers have 120 people and some people have 5, or what's the sweet spot, That's a big difference. There was also, number of licensed beds. But anyway, so the surprising results, most nurses reported either slight or moderate pressure. These people were not really stressed out according to the nurse stress index. And then the majority of the sample had good or excellent workability. That could mean a couple of things. Either they're lying or they're overestimating their health. There's not any objective measure in this study. Remember, I'm not out there taking their blood pressure, things like that. All right, here's when you get back to the mean, 73. And I think the score could range from 30 to 150, so it's kind of right there in the middle. And so looking at the literature, only 16% of the sample of nurse managers had nurse stress index totals that indicated greater than moderate to extreme stress, which actually contradicts the findings of these other authors, Kath, Steiker, and Earhart, in 2012, who reported levels of perceived job stress among nurse managers above the mean. So, but I don't really, at the time I probably looked at the scale, the work stress scale, and was more familiar with it. But we're using different instruments. We don't have a standardized way of measuring stress in nursing literature. I haven't found one. Have you all seen one? I've seen a lot of different things. I've seen instruments that are not put together well. Have you all seen that? They don't have good validity and things like that. The work ability scores. I had only 1 person in the poor category. That's good. Average 25, good. Everybody is either in our good, excellent, or they're average. There's actually more people over here. So 26 people in the lower group, and then this looks like 66 up there in the higher group. Anybody have questions about data? I know this is always so fun to look at. I actually love my data. I like spreadsheets. So most of our folks are over here. These are just some different ways of looking at it. I think it's nice to have the pictures. Because when you're looking, at that, you're just like, what does that mean? But, that's why when we had that project coordinator, it was so nice because he could bring little bar charts to the meetings and people could really see more, I think a lot easier, kind of what's going on. And you can spend hours doing this. You can never finish your dissertation because you're on Excel playing with the charts. So, but the workability scores were these results are similar to a Swedish study. N of 78, so that's fewer than I had. Even though the frontline nurse managers reported higher job demands, 88% of the nurse managers reported good or fairly good self-rated health. So this is actually matching up with what they found in Sweden. And I told you we had to dichotomize into 2 groups. This is our second part of AIM 1. And so 4 subscales, I think there were 6, only 4 of them had statistical significance. So you see this is the group with better workability, and this is the lower group. And so you can see kind of across the board some of the trivial demands. And this is what I thought ate up nurse managers' time demands and trivial tasks. I mean, that happens all day long to people. And then what about prioritizing your workload? Everything's a crisis, and you have to decide what's really a crisis, right? And then how supportive are our organizations? And then do we have homework conflict? Are we having problems at home that may be coming over to work? And then this is just the individual scores totaled together. So we see similar results. So some of the limitations, the sampling method and size, introduction of bias. I had one lady write me, and I was hoping she was going to get some people to take my survey, but she didn't like the fact that I had stress in the title. She thought that introduced a lot of bias, and even my chair wrote her a very nice explanation that was great. I couldn't reproduce it myself, but she still didn't want them to take the tool because she felt like it was biased. It's a self-reporting instrument. Do you guys who are newer to nursing understand what that means? I'm filling it out myself. And then I couldn't do a factor analysis on the NSI. So that was a limitation. I'm sure we could find some more. So this study does increase quantitative knowledge about nurse managers, about their work stress, about some of the variables like trivial tasks. And then I contributed new knowledge by using the workability index in a sample of American nurse managers, because they haven't done that over here. And I did do a poster at UTMB, and I had someone from the occupational health sciences stop and say, because it really does, it is kind of nice to try to dip a little bit into another area just to kind of bring more in. Do y'all understand what I'm saying when I'm looking at, I think all the stuff we've done with Pathway and Magnet, and it's great. But now I think let's look at the World Health Organization definition and see if we can't be a little innovative and make our workplaces more vibrant and healthy for the workers. So that's what I just said. Thank you very much. That's Lucy, and that's my newest grandson. And you can contact me at Gmail. I'm on Twitter at NurseBite, and you can find me on LinkedIn if anybody would like more details about my study or nurse management. So thank y'all very much. You did survive Joint Commission.
Because my name is Janet Vines. I'm a nurse manager over at Covenant. And Joint Commission is at our hospital this week. So let's talk about stress and how much we work to make sure everything is done. And it all turns out okay. So I actually did take Sarah's survey way back when, and I'm so glad now to have seen this.
Yeah.
I didn't really even
You knew what happened?
the results. But I think this would be a great study for one of your master's students to do another. Whenever you're talking about it not being found here in the United States, I thought that is so very true. But the stress relief. Who else is a nurse manager in here? See Jenny back there. The trivial tasks that we sometimes get, I hate to say sidetracked with. Whenever you have multiple employees who come up and whatever is on fire in their own life is truly, they want it to be on fire in your life, and you try to give them your undivided attention, although you have your own fires to put out. And how do you say that nicely? If there's a nurse manager who doesn't work the floor, I would be interested to know where they are. Because I may not work a whole shift, but I can tell you there are numerous mornings that I go in at 6 a.m. and help admit patients. And no, I'm not near as good as my admission nurses, but I can do it, and I can still start IVs, and I can still do all those things. And I'm there helping, and I think it makes a difference with the physicians when they see.
Well, and I think it makes a difference with your staff too.
Yes.
I mean, I know as a nurse, I always wanted to go take the blood pressure with the nursing assistant. I mean,
Yes.
always working together when you can, because then you build that relationship
And they'll do anything for you.
right.
And you know, that's probably the bigger key is whenever I've had, you know, physicians thinking I'm purposely trying to ruin their day. Well, I can't help that I've had people sick or something like that, but I'm here working, my educator's here working, and he just looks at me and goes, okay. And, but you know, we've all got to get in there and take care of it together. So that has been some of the big things. I can remember when I was actually in the BSN program here, and Ms. Locke, Patsy Locke, for those of you who knew her, came and spoke, and she told us, those of you who are nurse managers have the very toughest job. And I never really realized it, but as I've gone on being a manager, I live it day in and day out. Because it's trying to keep everyone happy. And from your staff to the people above you, and of course, most importantly, our patients. We have to do what's best for our patients. And then all the different generations we deal with these days. And I work in an area where there is a lot of people over the age of 50. Yeah. And in fact, I even found out the other day one of my employees was 76, and I had,
wow.
You know, you can't ask anyone how old they are, so you don't ever know how old they are.
I think that's really cool.
But I was very shocked that she was 76. And then I found out the other day someone else, one of the physicians I've worked with from the beginning of time told me he was 69. And he said, Janet, isn't it time to retire? And I thought, oh my gosh, we started at the same time. Now, I'm not in my 60s yet, but I thought, I had no idea that he was 69 too. So anyway, as we have had to learn how to handle these different generations and make some of our seasoned nurses handle some of these other generations, that has always been a challenge. I think one of the best things, and I've been privileged to be able to teach with Terry some out here in the leadership program, is to listen to these kids when they come back from following the nurse managers in the different areas. And the educators are like, I had no idea. Oh my gosh. And it was great. One of our students was with somebody one day whenever surveyors showed up. Like CMS or Medicare showed up, and they're cutting the whole day, the whole schedule changed. They were like, everything immediately changed. I went, yes. So everything that you have there is, yes, the different generations, the life we live each day, and the struggles that we have. I have finally got to the point that I have to realize everything will still be here tomorrow, and you just have to leave and go home. Because you do have to take care of yourself, and we don't do that well, because we provide care to everybody else. So, questions or comments that I could help you with, or? This is our class from last week. So thank you so much, and thank you
for having me. I appreciate all y'all coming. I know it's a long day to come out.
I appreciate the opportunity to come and be here to share some about what our life is like every day. So
awesome. I've got a question for Sarah.
Okay.
So what would your next step be now that you've accomplished this as a new nurse researcher who wants to contribute to?
I need to publish some of this. That's really what I need to do. But when you finish your dissertation, you don't want to write anything for a long time. And I had an editor, and I didn't realize people even did that, and that was a lifesaver because they have a template, the Texas, dissertation, whatever, and it all has to be put into this template, and I didn't have to deal with that. So, but I need to get some of this out there. It's important. And, we've been talking about stress in a long time for nursing. We've been talking about it, it's stressful. We need better work environments. I want to go to the cafeteria and have food that's nutritious, and I'd like to be able to go and sit outside and have some quiet time at lunch instead of always being TV or whatever. I mean, everybody's different. Some people are extroverts and they love all that constant. We need to be more human to each other, and we need our older workers. I mean, we do have a lot of age discrimination going on here. I've experienced that with my husband getting laid off, at the age of 52. But we are a bubble. I mean, there's a bubble of older folks, and we've got these great young people coming along, and we need to think outside the box, I think.
So I did tell her, You need to get with Joanne, because she will help you get this published.
Well, and I've worked with this Transforming Care at the Bedside, which is the Institute of Healthcare Improvement. Have anyone heard about Transforming Care at the Bedside? And it was set up on the Deming model of change, and you do these rapid tests of change, and it was geared to med-surg nurses because they always get ignored. And so they did all this with Johnson money, you know, one of those. But what we learned was it's the frontline nurses that know the best solutions. And so then when you test them out, and then you can roll them out, but the leadership is so important. You can't drive a change project or a process improvement or surgical site infection without those leaders driving it with your staff. You have to do it together. And that way we can make workplaces where the nurses are engaged, and then you end up with your magnet facility without even trying. So it's so
I think
important.
that's one of the biggest things I've learned too over time is in trying to hardwire different things is making my staff decide what it is that has to be done to make it work.
Because you know you've got your early adopters, right? Early adopters, and then the people that will never do it. Once I found that out, it was such a relief. Because sometimes you feel like I'm beating my head against the wall. Well, only 20 or 30% of people are going to come along at the first wave, right? You know, you're not going to get that big average group until you show some success with most things. But anyway.
How did you send out your data collection? I know you said it was on Survey.
Okay, so you get an account with SurveyMonkey. I think I actually used a paid account. But then you have to put all the questions in there in the right format. And then I made an error because I didn't include the question of how did you find out about this survey. So I couldn't look at that because there were 2 studies that talked about multimodal using the internet. And so I had some in my dissertation, some references to that. But then I couldn't go back and see, well, how did people hear about it? So, but you just put it on SurveyMonkey and then you download it and you have to turn everything into a number. And so you end up with a spreadsheet of data that is all there, and you have to code your instruments. And so one of the things I ran into was the NSI was very easy to code because it's all the same scale going left to right. The WI had 2 scales going in different directions, which causes other problems, and I didn't notice it at first. So the first time I coded it, I did the wrong, had to do it all over. But so you learn a lot. But it's not easy. Yes, sir?
More of a comment, I guess, and kind of bring it together. This is a very broad study and has a lot of information, but I think where a lot of the folks at Masters and DSM level can make this applicable is there's a great deal that speaks to things we already know about cognitive failure, errors, turnover, and this is a big foundational block in putting a pathway to connecting those things with workability index and that fills cognitive failures, mistakes at the bedside, and turnover in ICUs, and you know that's another
Right.
topic in research and whatnot. So yeah, fantastic topic.
What I really need is to get the data out so that other people can look at it, because there is a lot of qualitative stuff, but very little quantitative data. So I think you have to move across that continuum. I mean, qualitative is usually you start off with the qualitative, and then you build, and you end up you have to get the quantitative. But anyway, business case. So we don't, because like I said, it boils down to patient safety. If you're trying to reduce surgical site infections or prevent ulcers or improve your pain scores, you have to have leaders that are driving that, and then you have to have someone who's giving you the numbers. If we don't, I heard the other day, one of our patients developed a pressure sore after one of our cases. We don't know this. We think we're doing great. If no one comes back around and says, hey, you've had 3 patients get ulcers on their nose in the last year, we don't know. And when I was a first assistant and I went from working in the back and then following the surgeon, I thought, oh, look at those tape blisters. It changed the way I put tape on patients. So a lot of times we're doing things and we think we're doing great, but we don't know. So we're data driven. I don't think that's going to change. So we have to learn to support these roles. Yeah. Yeah.
I think that's the biggest problem.
Well, there's a lot of literature on coping with stress, and I didn't go there. I didn't even pull those articles. I just left that out because it looks real broad because I gave a lot of background, but you actually end up pretty small. Although I have a lot of stuff, so if any of your students are interested in using the data, I'd be willing to talk to you about that because it can be overwhelming. Yes, ma'am.
You made the comment that you would like to work with older nurses as well,
Mhm.
and really that's a huge value for an institution to keep that experience at the bedside. Value them, but also value our new nurses coming into the profession. What I was thinking about was, out of the research on wellness, of companies instituting wellness programs, taking care of their people, and seeing a reduction in health premiums and days of absenteeism,
Right.
you can't help but believe that a program such as this would also be.
Well, and that's what they use it for.
Institutions.
Like you can buy the tool, the WI tool, and use it in your occupational health to help take care of your employees. So they come in, they take it, and then you have an idea of where they are, and you can actually, what I've seen, we have some wellness programs at our job also, but I think we're just scratching the surface, because a lot of times it's, ticking the box that and I've lived in different cities and worked at different hospitals, and it does matter that culture you build, around nutrition and, things like that. Shift work, some people like 12, some like 8. Our younger workers want more flexibility. Are we gonna do that? Because I grew up right behind the baby boomers, and that's never gonna change for me, but we're pull our bootstraps on and keep on going people, for the most part, because that's how we've seen the world work. That's what we've seen. I worked for, my nurse manager was a baby boomer, and I realized we were different one day because she was sick, and she told me, I promised the nursing director that unless I was in the hospital, I would keep every bed in this unit open. And what I would do, if I was running the unit at night, I'd call the administrator and say, I've only got so many nurses, we can have 12 beds tonight, or we can have 18 beds, or whatever it might be. So we had this whole different approach to the problem, because I'm not willing to die for my job. I'm just not going to do it. And I hate seeing nurses, and I've seen it, where they become disabled, and they end up coming in your ER, and you're giving them charity care. These are people that have cared for others their whole life. So I don't know what the answer is, but, I think hospitals are backed into a corner because they're institutions that have been there for so long. Dell Children's, if you've never been to Dell Children's, go there when you're in Austin. It was built, it has like these little environmental gardens from around Texas. You go down to their cafeteria, and it's got a waterfall. It's a very different environment. And you can buy junk food in there, but you can also buy healthy food. And I know Austin's a pretty healthy city. They have less obesity than a lot of other communities in Texas. But I met a PhD student who was doing her dissertation, which is probably long done, on that building because of the way it was built. But I was working for a CEO who was in the same system. And he's building these runway hospitals. Big, Kyle, and then the one to the north. Big, like runway, and you're like, I'm supposed to prevent patient falls, and you've made my hall like this. So, there's a lot of exciting stuff that, people can do differently that's out there. And I just think we have to look for it and get involved with it. So.
I was just going to say, the link of stress from your reading Poncelia and the impact to your immune system. So, anything that we can do to all of the Shari's articles as being valued, and I make a difference, all the things that Shari talks about, but also the things that you talked about on having a healthy diet, going to the cafeteria and having healthy choices. Those are environmental factors as well that play a role in.
Yep.
I know recently food banks have talked about looking at healthier options because people are, receiving.
I'm surprised we're not fatter than we are, honestly. I've had a weight problem for a while now. But it's tough, it's tough to eat healthy. So, but a part of it's the culture. We like to eat together, and I actually posted a picture one day on Instagram. It was like hospital food killed. I took it out. I was afraid I was gonna get in trouble. It was something from the cafeteria line. I was like, I can't eat this, And I lost 9 pounds. I was at a desk job, and I went back to circulating a year ago. I lost 9 pounds without even trying, and I walk about 6,000 to 9,000 steps a day now, and I bring my lunch most of the time. So. All those birthday cakes. So. Well, thank you all so much. I really appreciate the audience. Nice to meet you all.
Thank you, everybody, for